Listen.
Good morning, everyone, and welcome to the House Committee on Health and Human Services and Elderly Affairs. We have several bills, and we have a couple of bills and a couple of House resolutions scheduled for consideration today. But before we get to those, I'd ask you to please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, everyone. First bill to be considered this morning is House Bill 732 FN, and I'll recognize the prime sponsor, Representative Glenn Cordelli. Welcome, Representative Cordelli.
Thank you, Mr. Chairman and committee members. It's a pleasure to be before this committee. For the record, my name is Glenn Cordelli, and I represent Tufton Borough, Wolfboro, and Ossipee in the beautiful Lakes region. House Bill 732 is really about parents' rights and transparency. It's about parents being aware of the risks associated with drugs that are being prescribed to their kids. This is about psychotropic drugs. And as indicated in lines 6 and 7 of the first page, this is already defined in statute, and I'll read that to you. They are a drug prescribed by a licensed medical practitioner to treat illnesses that affect psychological functioning, perception, behavior, or mood. Risks associated with some of these drugs include addiction, suicidal ideation, aggression, and hallucinations. Parents should be aware of the potential benefits and risks in what is being prescribed to their children. That is the intent of this bill. The requirements are very simple. Parents have to be presented with the FDA medication guidelines for the medication that the physician is suggested to be taken by their child under Medicaid. Why Medicaid? It is state and federally funded, and schools are doing billing for services under Medicaid. And what are these guidelines? The federal statutes define under 21 CFR 208.20 the FDA guidelines and what are to be included in the guidelines. Handed out for your inspection is a sample FDA guideline for Ritalin. And in section 5, you'll see the warnings and precautions about risk to patients, abuse, misuse, addiction. Those are the types of things that we want parents to be aware of. And these federal guidelines for the guidelines are very detailed, even to the font size that these guidelines have to be printed in. And this legislation requires that providers prescribing these drugs to minors review the FDA guideline for that medication with the parent and obtain their written consent, knowing the risks and potential side effects of the medication. I'll just mention also that DCYF, under their rules, monitors and oversees the use of these drugs for children who are in out-of-the-home placement. Parents whose children are at home should have the knowledge to know the risks and side effects so that they can oversee the use of these drugs by their child if they so choose to have them taken by their child. Also passed around are a couple of letters of support. They tried to mail them to the committee, but they got bounced back for some reason. And I'll point out that one of them is from the consumer representative on the FDA Drug Advisory Committee. This legislation will not take effect for another year, so it gives everyone plenty of time to prepare and become familiar with the FDA guidelines. There is a link that I can mail you if you could choose that you can go to from the FDA that will then show you all the guidelines that are available and have them available on PDF format. So let me just close by repeating that this is about the rights of parents to be aware of the risks possibly associated with the medication that is being prescribed, and about transparency. And I thank you very much for your time and attention.
Thank you. Representative Weber.
Thank you so much, and thank you for taking my questions. Just so I understand what we're talking about, what you are contemplating is if a provider was going to prescribe Ritalin to a child, this is the document that they would need to present to the parent and go over and then document that that had happened. Is that correct?
That is correct.
Okay, thank you. Yeah, I'll leave.
Representative Woods.
Thank you, Mr. Chair, and thanks for taking my question, which I will have some follow-on ones. The first one I have on my list is there any need to mention that oftentimes medication is prescribed for 3 months and then they're doing well, and then they're off for another 3 months or so, need to go back on the medication? Does this require that review to occur again? My reading is.
So if I understand your question correctly, if they're prescribed to take it for 3 months, 6 months or something, but then later on, the physician feels that the child needs to go back on that medication, yes, I would see there's nothing in here that says that they don't have to do that process again, go over the risks with the parent and get consent again.
So would there, so that leaves a little question about exactly when that is necessary on the part of the provider. They've been on it before, they've explained it before. So there's a question there. The second, it mentions parent or legal guardian. Oftentimes, kids that have mental difficulties are not with a parent or a guardian, or living with aunt or grandmother or something along that line. Also, some of them are incarcerated and not available to their, or in a psychiatric facility. How are those?
They would be handled by DCYF, as I indicated, as out-of-home placements.
So
if they were in a facility, for instance.
So there's no impact to those providers.
If they're prescribing under Medicaid, they still should review the medication guidelines with whoever is responsible at that facility.
So it's up in the air, okay.
But the basic issue is that DCYF is to monitor that. So I would expect that in a out-of-home placement, it well could be the DCYF case manager who is going over the risks of that medication with the child, because they are responsible for overseeing the medication.
Okay, so
You all set? Or?
no, go ahead, I'll come back.
Okay. Representative McLean, and then Representative Weber, and then Representative Hartnett.
Thank you, Mr. Chair, and thank you for taking my question. So I'm assuming, and I don't know, that there is some kind of consent currently. So how does this differ from the current state? And what is the need, I guess? So you have the current state, some need pushed us to a new place, and this fulfills that need. So could you kind of walk us through that?
Right. I think even when when I go to the Walgreens and pick up a prescription for my wife, they ask if we'd like to talk to the doctor. So those types of things are in place. But if it's a Medicaid involved prescription that's being provided, we would like this in place. And I think some of the letters that I passed out, especially from the consumer advocate for the FDA, will go into some of the other aspects of that.
That's it. I'll follow up.
So is it my understanding then that currently these discussions can happen, but they're voluntary?
I believe that's the
Makes it
case.
mandatory?
Right. This would make them mandatory and having written consent to document that information has been provided and is understood by the parent.
One more follow-up.
And so, as I read this, it does mandate a discussion. So when you're saying, make sure they understand, this is mandating a physical discussion as well?
Yes.
Thank you.
Representative Weber and then Representative Hartnett.
Thank you. One of Representative Wood's questions brought something new to my mind, which is that in the course of a child being in an out-of-home placement, it's very often that they are in the course of litigation about parental rights. And during the entire pendency of that litigation, the parents, of course, have their full parental rights. And one of the issues that is very difficult to deal with in some cases, where parents are not interested in actually pursuing their parental rights in the way that I might think they ought to, but they don't, is getting consent, which is required from parents now for all kinds of different things, ranging from a school trip all the way to important medication decisions. So if DCYF doesn't actually have the authority to give that consent, and the parent is either absent or unavailable or unwilling to engage, what do we do then if the child is in need of an intervention? And, for example, DCYF also believes that the child is in need of intervention.
I think that is an issue with the DCYF and their involvement with the case. I'm not familiar directly with DCYF procedures in that case, so I can't accurately provide you an answer for that. But I think that if the parent is not exercising parental responsibility or authority, and DCYF is involved, then DCYF would oversee the medication prescription.
Follow-up.
Would you understand the need that there might be a need there for a clarification because currently they can't? If you feel a clarification is needed in that regard, I would not object, and whatever you feel is necessary to. My intent is I want if there's parental involvement with the child, I want them to be aware of what the risks are, and that's my main intent. If you need clarification on a few points, I have no problem with that.
Representative Weber.
And not to beat a dead horse, but let me beat it one more time anyway. The concern that I have is, on the one hand, parents whose children have been removed from their care continue to have their parental rights. So this bill for those parents runs into the concern that on one hand, there are parental rights which are protected under the DCYF statutes that you are proposing to limit in some way that is still not particularly clear to all of us in this statute.
If you feel there's clarification needed in those instances, I would be glad to work with whoever on getting that clarification and putting that into an amendment.
Representative Hartnett,
Thank you, Mr. Chair. Thank you for taking the
should you
question.
bring your microphone a little closer?
Yeah. Go. Just had a question. Why just Medicaid recipients?
Basically, it's both state and federal funding is involved in that. It's felt that, for instance, in statute, we have medical providers, but Medicare really covers the gamut from state and federal. So we figured that was the best direction to take with that initially for this legislation.
Follow up?
Yeah. I'm assuming that the drive to generate this bill is essentially you think there needs to be a tightening up of practice here. I'm still not quite getting
Yeah, and
why.
I'm sorry.
I'm still not quite getting why it would just be focused on Medicaid recipients.
I think that there is an effort in many states to tighten up on the prescription of these psychotropic drugs and make sure that there's parental awareness before the medication is prescribed because of the risks involved in many cases. And so, I've talked with a number of agencies, including international agencies, about this, and work closely with them on the development of this legislation.
All set. Other questions? Representative McLean.
Thank you, Mr. Chair. and Thank you for taking my question. So I just want to follow up on Representative Weber's train of thought, but I want to flip it up a little bit. So she was asking you, sometimes it is difficult if the parents are not engaged to get consent. She talked about, I just want consent to send the folks on a field trip. Conversely, though, in your preparing for this bill, are you aware of instances where there are parents who are engaged and are trying to get this information that they are unable to do so and it has not been provided to them, and things are just prescribed without the consent? So it's voluntary right now. So are there instances, yes, I want to know what's going into my child and it's frustrating, I just can't do that? Are you aware of any of that?
Anecdotally, I've heard of parents really not being aware of all the risks and side effects of a medication that's being prescribed and might not be prepared for witnessing some of these side effects if they do occur. Because it's important that they know what the potential side effects are so that they can deal with it.
Follow up.
Thank you, Mr. Chair. And pardon my ignorance because my wife and I never had children, but if a school sees an issue where they want to prescribe, and you brought up Ritalin, is that done currently without notification to the parent at all? Or or they notify, but they're not having this level of consent? So how is it done right now?
Right. I believe that they would talk to the counselor would talk to the parent about, for instance, ADHD.
Right.
And suggest them to see a physician. There is incidentally legislation pending to make sure that prescriptions like that are not being done at the school level.
Okay. So it would be involved with the parent and then a follow-up discussion with the parents, with the child's physician
Correct.
currently.
That is my understanding.
Thank you.
Any other questions?
Yep.
Representative Hart and Representative Weber.
Thank you, Mr. Chair. Thank you for taking the question.
Sure.
Do you know of any other aspects in healthcare where we similarly dictate how a prescribing process would be undertaken?
I've never been on the Health and Human Services Committee, just on the Education Committee. But I have had 3 children, and I do not recall that. So I'm not sure the answer to your question.
Okay.
All set?
Yeah.
Representative Weber.
Thank you again. Having skimmed a little bit of the letter from the FDA advocate, it says the FDA develops medication guides to communicate these potential dangers in clear consumer-friendly language. Now, if I read from what you handed us, one of the points that they're supposed to look for is peripheral vasculopathy, including Raynaud's phenomenon. Careful observation for digital changes is necessary during Ritalin treatment. Further clinical evaluation, e.g. rheumatology referral, may be appropriate for patients who develop signs or symptoms of peripheral vasculopathy. Do you agree that that's user-friendly language?
It depends on the user. But I think that would be a point that the physician would be discussing with the parent. I think that the main thrust with the guideline is, as in Section 5, the abuse, misuse, and addiction, and other risks that are listed there. And I think that the physician would be perfectly capable of additionally considering user-friendly language. This might be user-friendly to the FDA, but maybe not to some of us.
If I may?
Follow up?
If I may, a suggestion I would make for revision, although I'm not sure I would agree with it even after that, is that somebody ought to do some work on whether, for example, the sections about risks during lactation are appropriate for when they're dealing with kids. But if this is what you want handed to a parent, do you think that a parent, even with a physician going over it, is actually going to be able to extract the information that they need to know about risks to their children? Or is there a different format that might be considerably more user-friendly?
This document is an FDA document. I think that with physician walkthrough, the parent would be aware of the risks involved and the potential benefits to their child.
Thank you.
Anyone else? Seeing no one else. Thank you.
Thank you very much.
Also signed up to speak is David Chorney from New Hampshire Medicaid.
Good morning, David Chorney, the Deputy Medicaid Director for the state of New Hampshire. Thank you for giving me the opportunity to testify this morning. I'm just here generally to provide some information, but had a couple comments on the legislation. I think as written, it appears the legislation really only applies to Medicaid enrolled children. And just for reference, that covers about less than 1 in 4 children in New Hampshire, so it's less than 25%. So a provider's patient panel, pediatric patient panel, 75% of the patients wouldn't necessarily apply to this higher standard of informed consent. And so we have some concerns that it could create provider abrasion where they're treating Medicaid patients differently than their other patients. And that could create access issues if providers didn't want to rearrange how they practice medicine just for a smaller portion of their patient panel. And access issues create costs and health outcome concerns for our Medicaid kids. There was also, I noticed it appears to maybe omit some prescribers of these psychotropic medicines. And I was thinking the advanced practice registered nurses are able to prescribe psychotropic medicine, but the reporting of noncompliance would go to the Board of Medicine, which doesn't oversee them. And so, similar concerns about creating provider confusion as to who can do what, when. And then Medicaid also has a unique mechanism that allows for retroactive enrollment. So someone could get care and then become Medicaid eligible or apply for Medicaid, and that enrollment can go back 90 days. And so I think one suggestion for the legislation would be to add a mechanism to address that, because the provider at the time of the prescribing wouldn't know that the patient in the future is going to become Medicaid enrolled. And then this higher informed consent standard would apply. And in talking with our medical director, Dr. Ballard, who is not able to be here this morning, but he also referenced there may be certain emergency situations where getting the enhanced informed consent from the parent isn't practicable for the emergency care that is necessary for the child. And then on the administrative side, we had some concerns because there's no appropriation, and there will be additional costs to investigate and ensure compliance to then suspend Medicaid claims and report to the Board of Medicine. But happy to answer any questions.
Representative Weber.
Thank you so much. Thank you for taking my question. Insofar as you know, because this may not be your bailiwick, could you describe to me what happens when a child is seen in the schools under the Medicaid rubric, and how consent is or is not obtained from a parent for a prescription now?
Yep. So currently there's a Medicaid to Schools program, and that provides Medicaid coverage for Medicaid services that a child enrolled in Medicaid would get as part of their IEP or 504 plan. And as part of the IEP process, parents consent and help develop the IEP plan and 504 plan with the schools. And if prescribing of one of these medications was part of that care plan or treatment plan, the informed consent would occur at that level. The Medicaid to Schools program is not like a clinic within a school just for Medicaid kids. It's specific to IEPs, 504 plans. So more of that special education, the medical component of that special education piece.
Could I? Thank you. And I'm just trying to understand how that program works. So in the case of a child who had a 504 plan or an IEP that suggests that they need psychotropic medication in order for them to be able to fully participate in their educational plan at school, would they be seen in the school or in a physician or other provider's office? I assume that an advanced practice nurse practitioner might be the provider that they would see.
I think in many cases they would be seen by their in a primary care practice outside the school for the prescribing of that medication. I think the IEP or 504 plan that is consented to would be about administering that drug if it would needed to be administered at school.
Okay.
But there are some clinicians that I think do come to the school, and if that was a part of it, I guess it could be. But
And follow up. And in all cases where a child would be seen by a provider for evaluation and prescription of psychotropic medications, would the parent not be required right now to give their informed consent to that treatment?
Yeah, with any medical treatment, informed consent is an inherent part of the process. And for minors, it has to come from the parent or legal guardian.
And I did have one other that goes in a different direction. If one of the things that somebody decided was necessary was that there was a disclosure that didn't look like this, but that was actually written in more plain English, because I have 20 years of formal education and I can't read this, would there be a cost to the department if the department was designated as the agency to develop those materials?
I think it would depend on the scope of the department's involvement. There would be, a resource cost to develop the material, but if the department had to print it and mail it and provide it to providers, that would be, another cost.
Thank you.
Representative Mazur.
Thank you, Mr. Chair. So in reading this bill, I just see that it's requiring providers to take an extra few minutes to provide some FDA information, including some risks, which I think are very important. So I'm still failing to understand, maybe you can help me. I'm asking the question of why this would be a bad thing.
Oh, I'm not saying it's necessarily a bad thing. It's just that it's specific to Medicaid and it's not specific to all children that a provider would treat. So the provider will have to do something different for Medicaid patients than they do for all of their other patients. And Medicaid is a small portion of any provider's patient panel. Just on average in New Hampshire, it's less than 1 in 4 children.
Representative McLean.
Thank you, Mr. Chair. If I could ask 2 questions?
Sure.
Thank you for taking my question. So the first question, again, following up on Representative Weber with respect to presenting something that is more understandable to the parent, is what's provided, because this whole thing is very complex, I agree, but the actual medication guide called for in the bill, I believe, is just the final page of this handout, right? So they wouldn't be looking to digest all of this, which I agree is very complex. But the medication guide for discussion asked for in the bill is just this final page, right? So so would we want to be, is that clear enough, or would you want to maybe modify that further?
I may ask our pharmacy director to help, to help answer that question, because I think she has a little bit more experience in the FDA. Is that
Sure, if she
okay?
wants to come up, sure.
Okay.
Hi, Margaret Clifford. I'm the pharmacy director for New Hampshire Medicaid. I don't have the handout that you have in front of you, so
Can everyone hear okay?
No,
Could you,
okay.
you
So
need to
then-
have the mic right in front of you.
So the handout has the FDA document, but I don't believe the whole of the document is what's required to be shared, just the medication guide at the back. And I just wanted to clarify that.
Okay.
you just shut it off.
Okay. I thought red might be off. Yeah, it would just be the last section.
Okay, thank you. And then my second,
Sure.
my second question, thank you, Mr. Chair. So my second question is, you did bring up some concerns. If this bill were to be revisited, because I was kind of thinking, since it was going through the schools, everybody, whether you're on private insurance or not, was kind of going through that Medicaid rubric. But I think Representative Weber's questioning has kind of clarified that for us. So if we were to, number one, make it an across-the-board requirement and not just carving out Medicaid, and number two, go back to your other concern, which was with respect to ARPNs. If it goes back to the Board of Medicine, ARPNs are not accountable to the Board of Medicine. So basically, revisiting the reporting structure, if we were to address those two issues with the bill, does that address the bulk of your concerns, or are there other things that are still kind of hanging out there you're nervous about?
The only there are two other. One is the retroactive enrollment. Just unlike primary insurance, where you don't get coverage until you're enrolled in Medicaid, you could see a provider and then apply for Medicaid, become Medicaid enrolled, and that Medicaid coverage can retro back up to 90 days.
Okay.
So it would cover that portion. So just having a mechanism, well, I guess if it applies to all kids universally, that's actually not wouldn't be an issue. That would be if it would just apply to Medicaid. So sorry. I think just the emergency situations exception. And then I do know this would create some cost or resources to DCYF. And I think that's already been raised, and getting DCYF's input on that.
Thank you both for the clarification.
Representative Drew.
Under what circumstances would one emergency prescribe Ritalin? Do you know?
I don't know. I don't have a medical background, but it was something our medical director brought up. But he's unfortunately out this week.
Anyone else? Seeing no one else? Okay, thank you. No one else has signed up to testify on this bill. Does anyone else wish to testify? Seeing no one, I'm going to close the public hearing on HB 732 FN. We next scheduled to hear HR 16 at 10:30, so we will be in recess until then. Good morning, everyone, and welcome back to the House Committee on Health and Human Services and Elderly Affairs. The next item for our consideration is House Resolution number 16. I'll recognize the prime sponsor, Representative Jack Flanagan from Hillsborough County, District 45.
Thank you, Mr. Chairman, and you're taking all of my speech. I was asked by former members of the House that are behind me in the audience that are going to testify to submit this resolution to support and also basically provide some platform for people to know how hard they worked during the COVID pandemic. And, you know, over time we have, and let me preface that by saying I come from a family of healthcare providers. A nurse, my mother was a nurse, my father was a dentist, and believe it or not, that's healthcare. And my uncle, who's still alive, was a retired surgeon. So there's a healthcare background in me. But what happens is over time, I think we tend to forget how bad COVID-19 really was, especially during its initial exposure to the public. That people, I have friends that have died from COVID. But, and unfortunately it was before the immunization process came out. So, you know, God rest his soul, Bob Berger. But I think the thing is that over time we forget how deadly that virus really was. And having healthcare providers working during that part, you know, unknown, whether they're bringing it home to their families and things like that, I think it's important that we basically have a, you know, a resolution from this body saying how much we thank them and how much we really appreciate the work that they did where a lot of people just wouldn't do it. And with that, I'm going to defer any further testimony to the other two the honorable representatives to talk about maybe some of their experiences, but I'll answer anybody's question too, because everybody knows me here, knows that I'll answer a question that someone may come from my testimony.
Okay, thank you. Are there any questions for Representative Flanagan? Not seeing any.
You're letting me off the hook.
We're letting you off the hook.
I always appreciate it.
Thank you. Also signed up to speak is former Representative Lynn Blankenbecker.
I got it.
Hi, good morning, Mr. Chair, Mr. Vice Chair, honorable members of the Health and Human Services and Elderly Affairs Committee. Thank you so much for the opportunity to speak on what I think is a very important resolution today. I stand in support of this resolution. So I've been a nurse in New Hampshire since 1993, but I've never served in this capacity for any recognition at all. I earned the title of RN, which I'm very proud to have had my entire career. And I take great pride in caring for people at arguably the most vulnerable times of their lives. I love my time as a nurse. I am now retired. I finally retired from nursing, but I love my time as a nurse, and I found my experiences with my patients and their loved ones and in my community to be most rewarding. During the COVID-19 pandemic, it was a very difficult time, as you all know, for our nation and for our state, especially for our healthcare workers, all of our frontline workers. And that's not just nurses, it's doctors, nurses, dentists, you know, ancillary services, our EMT, everybody. And it was for many reasons. The logistics made it very difficult to care. It made it almost nearly impossible, from lack of supplies to inconsistent and oftentimes contradictory guidance from the CDC and our state and our national government as to what the rules were regarding care delivery. And those were ever changing. Nurses, as a nurse, we were required to use innovation. We were required to use ingenuity, anything we had in order to properly address the healthcare needs of those we served. Fear was another big issue, and it was crippling. Patients were afraid, and they presented questions that nurses, as that I couldn't answer for the first times, which was, you know, a very uncomfortable place to be as a nurse, and not being able to answer questions that your patients or their family members may have had. Some healthcare workers were so paralyzed with fear that they opted to shelter at home, and that created critical staffing shortages during this time. And we had a very exhausted workforce during that whole period. National fear created a situation of lockdown of our hospitals, which separated families from their ill loved ones, and that only increased the fear and anxiety across this country with respect to COVID. Yet, nurses, doctors, ancillary staff, first responders, and all other healthcare workers bravely served, knowing that they could become ill with COVID themselves, and knowing that their days would carry extra stressors that revolved around staffing shortages, limited resources, additional testing, isolation requirements, and most importantly, our patients with exacerbated fear and anxiety related to the isolation and the separation. But we still stepped up. We stepped up and we provided compassionate and understanding care, all while fighting an invisible enemy and adapting to almost daily new mandates to our care delivery. In my 36 years as a civilian nurse and as a military nurse, I cared for people and their loved ones in every situation, good and bad. I've delivered babies, which is a very happy time, and I've also provided care in a battlefield in war zones. I've responded when our community has needed me, and I served aboard the UNS Comfort when it went to New York City and provided COVID relief to a city that was especially hard hit. I, in fact, got COVID on that ship and understand the isolation as I was quarantined for over a month as a result of contracting COVID while I was on the ship. When I returned from New York City, I was working as a prosecutor in Hillsborough County, but I also recognized that I'm also an attorney. But I also, they don't put nurses as prosecutors. I probably should have clarified that. But I also recognized that our community really desperately needed nurses. So Monday through Friday, I worked as a prosecutor for Hillsborough County. And then on Saturdays and Sundays, I worked in a nursing home to provide care there because they were desperate for nurses. My clinical skills were put to good use, but it was my human skills that mattered the most. The nursing home facility that I worked in, like I said, it had huge shortages. And because at that time, the rules were families couldn't be with their elderly family members in these facilities, I sat with a lot of people who died, and they would have died otherwise alone. But the sad part of that was that those folks died without their family with them, and I became their family for that short period of time. I don't think that brought much comfort to anybody. It didn't bring comfort to the families, for sure, who couldn't be with their loved one to say their final goodbyes. It didn't bring comfort to the patient or the resident to not have their family member with them. And it certainly didn't make me feel good knowing that I was the only person that was going to be there with them during this time. That was because of policies where we just were not allowed to have family members with their loved ones as they were dying. But that was the standard of care, and those experiences have have left indelible marks, I think, on our healthcare providers across this state, especially, and our nation during that most scary and uncertain time. So as I stated at the beginning of my testimony, I don't need personal recognition for my service to our state or to my nation during the COVID pandemic and all of the response efforts. However, I believe this resolution is a positive gesture by our state that validates the hard emotions that healthcare workers experienced during the pandemic, and it provides a state understanding of those difficult days that we all endured, and offers some healing for those of us who experienced a whole gamut of feelings at a time when healthcare delivery in our history was uncertain, chaotic, filled with fear, ever-changing, and the rules dominated our personal and professional lives. So I thank you for the opportunity to share my thoughts today. I hope all of you who experienced COVID in a way that is unique to you and your families, had positive outcomes for you. I know it was a tough time for all of us, and I would urge you to consider a vote in support of HR 16, because I do think it's a collective giant hug from the state of New Hampshire to those on this 5-year anniversary. Believe it or not, it's been 5 years since all of this started, just to recognize and say thank you for your service. So with that, I'll answer any questions.
Are there any questions for Representative Blankenbecker? Representative McLean?
Thank you, Mr. Chair, and thank you for taking my question. I mean, I think everybody recognizes that the contribution of our healthcare workers through COVID was Herculean. I'm just wondering, with this resolution, how is it going to be communicated? I mean, how are people who served during that time even going to know that it exists? And so I guess we approve it. Where does it go from here?
Thanks for that question. So obviously it'll be get read on the House floor. I hope the media will cover it, and so it'll get sent out that way. There's a lot of organizations here, lobbyists, the ANA, the American Nurses Association, the American Medical, the State Nurses Association, the State Medical Association. You've got your state EMTs, paramedics, your first responders associations. All of them have a legislative liaison who will be tracking any kind of legislation or HRs that come out. They should be conveying those back. Good news stories. I mean, today we don't have a lot of good news stories. Every time you turn on the TV or every time you open the paper, you don't get a lot of really good news stories. And so when there is a good news stories, I feel like we're unique in the state of New Hampshire that gets to be a headliner. And so I would hope that the local papers and that the local TV stations and radio stations would also recognize when they're broadcasting about legislation or about activities that go on in the House, that they'll broadcast that. I was a member of the New Hampshire Nurses Association, and so these types of things would get shared with us down the road, down the line.
Thank you.
Anyone else? Any other questions? Okay, thank you.
Thank you so much. And thank you guys, for each of you, for what you do every day. I know that you guys are all working on what you believe is in the best interest of our state. And I know how hard it is to sacrifice your time and your talents to be able to help us. So thank you so much for what you do as service. I know it's not a very highly paid job.
Thank you.
Thank you.
Also signed up to speak is Representative Henry Gasson. Guyson, I'm sorry.
Thank you, Mr. Chair, honorable members of the committee. So I want to speak in support of this from somebody who actually was a responder and let you guys know a little bit about my experience and what I witnessed. So at the time the COVID-19 pandemic broke out, I was actually I was the operations sergeant for the 101st Engineer Battalion, Massachusetts National Guard. I'm a New Hampshire resident. I was working for Massachusetts. And that first few weeks, it was all hands on deck to build field hospitals in every concert stadium, venue, every place that we could find, and then coordinate with other agencies, with FEMA, with local hospitals, et cetera, on how they were going to be staffed if a hospital system was overwhelmed. After that, it became massive coordination with healthcare providers, including trying to fill in some of their gaps. We, had a veterans home where the whole staff got COVID, and we had soldiers pretending to be healthcare workers trying to staff that home. Healthcare workers were working multiple shifts back to back. You were either sick at home or you were at work. There was no vacation. There was no rest cycle. There was infinite overtime, whether it was funded or not. You were either sick or you were at work, and if you were working a double or even a triple, even though that's not legal, that's where you were, because that's where the people needed you to be. There were medical providers that were covering shifts that were not in their specialty. You may have had a NICU nurse covering trauma because that's where the need was at that time. So there was a lot of cross play among healthcare providers just to fill in the gaps, and that led to extensive family separation, extensive burnout as well. I actually have an acquaintance who was an EMT for 15 years going into the COVID pandemic, and then afterwards That person left their trade to go back to college because they were developing PTSD from being in an ambulance all the time. So if this is a small thing that we as a state can do to recognize the people that took the brunt of that force, head on, whether they were ready or not, because no one is ever ready for that kind of operation, then I recommend that we pass this resolution. Thank you for your time.
Thank you. Any questions? Seeing none, thank you. Also signed up to speak is Representative Ellen Reed from Rockingham 10.
Thank you, Mr. Chair. Thank you, honorable members. For the record, my name is Ellen Reed. I represent Rockingham 10, Newmarket and Newfields. This is obviously a no-brainer. I can't imagine anyone being opposed to this resolution, but I want to honor the testimony that came before me of people who saw the situation on the ground firsthand of healthcare workers during that time. I am not a healthcare worker. No one in my immediate family or in my immediate friends are healthcare workers, so I am not going to speak to that aspect. I trust everything that has been told to me about what it was like. I'm going to speak to the perspective of someone being in office during that time, because me and I think only a couple of people here actually were serving when COVID became the thing that we all learned it would be. So just generally in our culture, we give a lot of praise, and often rightly so, to law enforcement officers, to veterans who've served, because these are people who we acknowledge are risking their lives for the public. We almost never give that level of praise, and certainly not the level of benefits, freebies, discounts to healthcare workers for their service. But this pandemic highlighted the fact that they indeed do risk their very lives. Just on the numbers, I quickly Googled 1,500 healthcare workers died directly during the phase that was the pandemic of COVID that they contracted in service. 100,000, that's across the country. I don't have New Hampshire specific numbers, 100,000 worldwide. So I think it's extremely important to acknowledge that these people were in fact risking their lives. And in fact, this was a time that as a legislator, there was a lot of talk about who was essential and who was not essential insofar as their occupation goes. And I would argue heavily that at any time, healthcare workers are one of the most essential professions that we could possibly have, more essential even than law enforcement, more essential even than national defense, which I'm not saying those aren't essential. I'm saying that if you don't have people surviving, if you don't have people who can stay alive, there's nothing to defend, and there are no laws left to enforce. So to my perspective, we were declaring all these different people, essential, non-essential, what have you. We sent grocery baggers to work, some of whom were actually elderly, which is another social commentary that can be made during that time as essential workers. You know who wasn't essential, apparently? And this is where I'm going to get a little bit maybe controversial. We apparently weren't. We weren't. I contacted the Speaker's office so many times for 3 solid months, begging, pleading, please, can we please meet? Can we do something about this terrible pandemic? We abdicated all of our responsibility. We took the sacred duty that we were entrusted with by being voted into office, specifically for when we needed to do something for the people like that. And we just said, no, too dangerous for us. But we made sure all those other people went to work. And we didn't. And that bothered me deeply at the time. And not only did we not act on that terrible crisis that was happening, we didn't even do our regular job. 700 bills died because of inaction, because we blew by the deadlines and didn't do anything about it. We just put our hands in the air. An entire one of the 3 branches of government just said, nope, we're not doing it. So I think healthcare workers deserve a lot more than a resolution, a lot more. But at the very, very least, we can give them a resolution telling them that, yes, what we were not willing to do, not even a little bit, you all were willing to do times 100. So that is my perspective as a non-healthcare worker at the time. And I don't know what questions you could possibly have, but I'm happy to take them.
Are there any questions? Not seeing any. Thank you.
Thank you.
Also signed up to speak is former Representative Werner Horn. HORN, yes. Representative Horn, actually, I think was this was your idea, right? You had called me and you had called Representative Flanagan. So thank you for bringing this to us.
Good morning, Mr. Chairman. You are, of course, correct. Members of HHS and EA, kind of a long title. For the record, my name is Werner Horn. I want to thank you for considering the House resolution today. And as some of the previous speakers have touched on, 5 years ago, this March 16th, we shut New Hampshire down. We divided up our population between essential and non-essential workers, and we didn't ask permission. We just told you, you're essential, go do your job. And when you have movies being made about veterans, when you have movies being made about law enforcement, there are precious few movies being made about frontline healthcare workers. And to the good representative's point, we might intellectually be aware of the sacrifices, but my concern and the reason for this is we need to explicitly state how grateful we are that these people made the ultimate sacrifice in some cases. The national statistics, 100,000 plus. I can't imagine what families went through in New Hampshire who had frontline healthcare workers become sick and die because somebody declared them essential. I want to make sure that the politics that went into this COVID crisis aren't affected by this. This isn't about politics. This isn't about right or left. This is about the fact that when you step up, answer the call, sacrifice by passing, by getting sick and contracting lifelong illness, you need to know that that was important. You need to know that that was recognized. And one of the mechanisms we have in New Hampshire are the House resolutions. The House has an opportunity to establish their position on the sacrifices made by the frontline healthcare workers. I was in office. I was on my county's nursing home subcommittee. I had a front row seat to some of the stories that were coming out, stories you've heard from previous speakers. People who were gathered outside the window of a loved one. And when you had nursing home workers who were seeing that kind of misery firsthand on a repeated basis, that's not necessarily what they thought they were getting into when they applied for those positions. That you would be declared essential, that most supports that they had depended on would be evaporated, that staffing problems would complicate your position in ways nobody could have anticipated. For those reasons, I would urge the passage of HR 16, send it to the governor's desk so that New Hampshire can send a clear and unambiguous signal that this is something we care about. That the people who sacrificed during the COVID crisis are recognized and valued. And with that, I'm happy to answer questions.
Are there any questions? Seeing none.
Thank you for your consideration.
No one else has signed up to testify on this resolution. Does anyone else wish to testify? Seeing no one, I'm going to close the public hearing on HR 16. The next item for our consideration is House Resolution 14, and it's scheduled at 11:30. We'll be in recess until then.
Appreciate you all being here.
Okay, I'll formally call us to order. And again, thank you, Representative McFarland, for being here. You are the prime sponsor of the next item on our agenda, which is HR 14, House Resolution HR 14. And please proceed.
Thank you, Mr. Chairman. Good morning, Mr. Chairman, honourable members. This testimony represents my views and the views and interests of my constituents in Grafton 18, and I believe of healthcare consumers across the state. My testimony is not made on behalf of any private employer, nor should it be construed to represent the views of any of my employers. I'm Representative Donald McFarland from Orange, and I'm here today because every Granite Stater deserves access to affordable, high-quality healthcare, not a system where monopolies drive up prices and limit patient choices. Our constituents deserve a fair and transparent healthcare system, one where patients are treated equally, not based on whether they have insurance or with whom, but based on their medical needs. At its core, HR 14 is about fairness and protecting our communities. We've all heard the stories. Families struggling to pay for basic care, seniors unable to afford prescriptions, others who don't even seek care because they feel they will not be able to afford it, and small businesses burdened by rising insurance premiums. These aren't just statistics. They're our friends, they're our neighbours, and our loved ones. And when healthcare providers consolidate their power unchecked, these struggles become even worse. Patients lose, and big corporations win. What HR 14 does is simple. It calls on our Attorney General to take a harder look at the ways monopolistic healthcare practices and pharmaceutical practices are harming the people of New Hampshire. It's not about punishing success, it's about ensuring fairness in a system that should put patients first, not corporate profits. Imagine walking into a grocery store where the price of milk depends not on its cost, but on who you are. One shopper pays $3, another pays $15, and yet another is told they can only buy it if they agree to a long, complicated payment plan. That would be outrageous, but it's exactly how pricing works in our healthcare and pharmaceutical systems today. Right now, the cost of medical care is not determined by what a service actually costs to provide, nor by fair competitive market forces, but by opaque and arbitrary pricing schemes set by powerful hospital systems. Patients are charged wildly different prices for the same procedure, not based on lawful price structuring, but based on who their insurer is or whether they have insurance at all. A privately insured patient might pay 3 times less than someone paying cash. A Medicare patient is charged one rate, while a self-employed person with a high deductible plan is charged another. A small business owner might pay an inflated rate just because they don't belong to a large corporate insurance network. And the same holds true for drugs. The exact same bottle of insulin from an American manufacturer is sold for one price in Canada and 4 times that price here in New Hampshire. An antivenin in Texas is sold for 20 times the price which the same manufacturer obtains for the same product in Mexico. This is not a free market. This is price fixing by monopoly power. When a patient needs care, they should know what they'll be charged, and they should not be gouged based on who they are, who their employer is, whether they're self-employed or whether they have the wrong insurance plan. The United States Supreme Court has already ruled that price-fixing schemes like these violate federal antitrust law, and you'll see that I have cited 2 cases in the resolution. Let me highlight those cases for you. In Group Life and Health Insurance Company versus Royal Drug Company, the Supreme Court ruled that healthcare markets, including insurers and providers, must comply with antitrust laws. The ruling confirmed that pricing agreements designed to exclude competition are unlawful. In Arizona versus Maricopa County, the court ruled that medical providers cannot set fixed non-competitive prices for different groups of consumers, and it rejected the idea that healthcare should be exempt from fair pricing and competition laws. These rulings make it clear healthcare is not above the law. Hospitals and insurers cannot create arbitrary pricing structures that have no basis in actual costs, but are simply designed to extract the maximum possible revenue from different patients. And as you'll see in the resolution, we have seen that revenue increase relative to GDP in ways that are unacceptable. We are seeing healthcare 20% of GDP today, and only a few short decades ago, it was at 4 or 5% of GDP. I could go on, but I think that this committee well understands this problem and well understands that what is needed is action by the Attorney General and by the other states' Attorneys General. And so I urge your support for HR 14, and I'm happy to yield to questions. Thank you, Mr. Chairman.
Thank you. Any questions? Representative Weber, sorry.
Thank you, Mr. Chairman, and thank you for taking my question. I don't disagree with anything you have said, and you've given a great overview of the problem. What I want to know is why you have chosen to bring this as a resolution which has no force in law. That's sort of question number one. And if I may, I'll just ask the corollary question. If anything is to be investigated, there are associated costs. And of course, we do not investigate costs when there is a resolution. But have you done any investigation about the costs that might be involved in doing what your resolution asks?
Great question, or set of questions. So let me respond to those in turn. First of all, I actually did start off with this intended to be a bill, and intended to be a bill that would not mandate that the Attorney General prosecute certain entities, because that would be a conflict of, the separation of powers, but at least require certain reporting from him and require other actions by the Attorney General's office. I was not able to get to a version of that bill language, courtesy of OLS, that I thought was viable. And I decided that the better course of action than present to you a bill that I myself didn't think was in good order was to submit this resolution this year and hope that the AG respects our point of view and takes action. And if that doesn't come to pass, I think that there are other actions that this body and the General Court can take. I will tell you, though, that in the course of preparing that language that ultimately I didn't move forward with, I spoke with the Attorney General on a couple of occasions. He expressed that he is interested and understands the concern, and I think to some extent shares the concern, although I did not get ultimately any firm point of view from him as to whether he believes that this is a set of problems he wants to move forward with. But I certainly, in the course of that, and in the course of my conversations with the legislative researchers, talked about the potential financial impact. In fact, in one version of my draft, I had contemplated making a stipulation about a line item in the budget for it. And what I received back was strong guidance that was unnecessary, strong guidance from both legislative services and frankly from the AG's office that they are already afforded the ability to direct their attention to where they see fit. And I think the question at hand is whether they should be looking in this particular direction. And if they do, I am sure that in the course of winning some of these lawsuits, they would be able to recover any costs they might have.
Other questions? Representative Woods.
Thank you, Mr. Chair, and thank you for taking my question. I certainly understand the intent, and from my personal perspective, I would certainly agree at the face of it. However, would it be that in fact this should be directed in a slightly different direction? And by that I mean it seems like this carries the assumption that a market-based system is the system that we should work with. Whereas there have been some questions that if this were healthcare were not delivered on a market-based system, that the problems that you've addressed would in fact go away. Would you care to address that?
I'd be happy to address that, Representative. And can I just understand essentially what you're asking? Are you asking, would we be better off with a cooperative system?
There's a variety of systems, one of which would be a single payer.
So, I mean, first and foremost, I would say to you that that is not the basis of our country and of our Constitution, either at the federal level or at the state level. I believe in free markets. I don't believe that we have free markets in all cases, just as I described here. But I would also point you, rather than making my response be based upon our particular points of view on these things, I would point you to the Supreme Court ruling itself that I referenced. And so, you know, if I look at the ruling in one second here. If I look at the ruling in Group Life versus Royal Drug, right, that ruling makes it abundantly clear that cooperative pricing is not, in fact, lawful under our Constitution. And I think that when you talk about other structures such as single payer systems, they too have profound constitutional problems.
Other questions? Representative Lucas and then Representative McLean.
Thank you, Mr. Chair, and thank you for being here and taking my question. I'm interested in your opinion about so-called cherry picking when the free market results in facilities that provide care basically to a healthier, better insured population, and then leaving the higher acuity, by necessary more expensive care, to other facilities that take all comers.
Thank you. So first of all, and if I may, can I just ask you, or ask the representative, Mr. Chairman, are you familiar with the Surgery Center of Oklahoma?
I'm not.
Okay. I would recommend the committee as an example of an institution that works with strong price transparency to take a look at the website for the Surgery City of Oklahoma, where they publish pricing for a variety of procedures. And I grant you that that particular example is an example of an institution that does not provide every possible healthcare procedure. But I think it is instructive when you look at that to be able to compare the pricing for those procedures that it does service to the pricing for those procedures that you see from our hospitals here in state. And so back to your question, do I believe that we have healthcare institutions today that are increasing the price arbitrarily on one procedure in order to subsidize another procedure? Yes, I do. And I find that to be in contravention of our laws, both our state laws and our federal laws. And we should be holding them to account for that. That is not to say that we should not be charging more for an emergency procedure than for a procedure which is scheduled a month in advance in the middle of a weekday. But it is to say that when we have one person forced to subsidize another, that in of itself is a violation of our antitrust laws. And I would argue that the words that we should be using around that include words like racketeering, corruption, and fraud.
Representative McLean.
Thank you, Mr. Chair. Thank you for taking my question. So it is within the Attorney General's purview to go and investigate fraud, if it exists. But it's not within the Attorney General's purview to maybe go in and investigate, the basic structure. There are other agencies that kind of do that. But if there is fraud, it's definitely within his purview to go after it. So, but this resolution kind of presupposes that a lot of what's driving the high pricing is indeed fraud, antitrust, things of that nature. At least as I read it, it's kind of implied in the findings in the resolution. So I'm just wondering, you know, not knowing for sure that it is fraud, but maybe it is just a structural problem on what, because we don't just investigate organizations. There has to be a crime to just, so on what basis, on what legal basis, do you think the Attorney General can proceed? Do you think there is enough with this to proceed? Are there other states that have gone forward and you know, we're going to open up an investigation because yes, we think that it is fraud? And so I guess I'm asking the question poorly, but what is the legal basis upon which he could initiate the investigation, and where do you see that within this resolution?
Okay. So I think there's a lot of questions that you asked in there, but I'll try and respond to the gist of what I understand them to be. First of all, the Attorney General is not unable to investigate entities before he has determined that there is a crime that has occurred. To the contrary, that's the point of our judicial system, is to determine whether there's a crime that's occurred. The Attorney General can choose to investigate based upon suspicion, probable cause, and so forth, and not merely of fraud. We have an entire chapter in our statutes here in New Hampshire that addresses antitrust law. And so what I'm suggesting in this resolution is not that out of the gate he should just go and start prosecuting people. I am suggesting that he should investigate and turn some attention to this matter. And if he finds cause to do so, then yes, of course, he should take action. Those actions are literally what that office does every day. And I don't think that there's anything in what I'm putting forward here which limits his ability to operate in the way that he would at any other time.
Thank you very much, and that's very illuminating. Are you aware of any other states that have had similar resolutions and have kind of gone down this path and have found anything substantive?
Thank you for the question. Yeah, I am aware that since those Supreme Court rulings came out, we have, and by the way, they are from 1979 and 1982, we have seen next to no enforcement of the outcomes that follow from those rulings. And I put it to you that the reason we have seen that is because the healthcare lobby is strong and has only been getting stronger and stronger over the last decades.
Thank you.
Other questions, Representative Weber?
Thank you so much, and thank you for the indulgence of another question. And I understand your point, which is well taken, about matching the actual costs with the actual procedure. Does that mean that you would also support ensuring that Medicaid was well enough funded to pay the full amount of the cost of every procedure and service that is rendered to Medicaid patients?
So I don't think that's germane to this resolution. I'm happy to have a conversation with you in the cafeteria about Medicaid and Medicare. And in point of fact, I had intended to bring a bill not unrelated to that this year, but again, I didn't get to where I wanted with OLS, but maybe we'll be talking in another year.
Thank you.
Other discussion? Any other questions?
Question.
Representative Tejas.
Hi. Thank you, and thank you for taking my question. So I'm a little confused because part of what I heard you mention was different people or payers pay different rates for the same service. But that is sort of the foundation of how our healthcare system works, right? Insurers have purchasing power, and so they negotiate different rates for paying. So at least as far as the costs of healthcare paid by insurance or paid by individuals, that seems like an insurance issue. And I'm curious why you wouldn't be taking it there. And also just it seems like the most American thing we have, right? Which is business operating as business does.
So, I mean, first of all, you say that our healthcare system works. I would beg to differ. I think that what you just outlined is part of the problem. If I pull up at a gas station, I expect to be able to fill my car for the posted price per gallon. I do not expect to be questioned as to what car insurance I have, or to have my car looked at to determine whether or not the color of the car or the model is relevant to changing the price. And so, you know, what you're talking about is a model that is not based upon proper commercial practices where, for example, if I go to a manufacturer and I say I would like to purchase 100 widgets of X, they may give me a discount versus if I go to purchase one widget. It is certainly cheaper for a healthcare provider or anyone else, any other company, to sell 100 units at the same time to the same person as to sell them individually to 100 different people with 100 different circumstances and 100 different sets of invoices and so forth. But that is not the case when you have insurers. I know that there are contracts that are structured to claim that that is the predicate for some of this variable pricing. However, that is one of the issues that the Supreme Court ruled against. And so I think that if you take a look at the case law on this, you will find that there is a case to be pursued here. And look, I'm not a lawyer. I believe that the Attorney General is far more capable of making those determinations than I am, and that our courts are as well. And I look forward to that happening.
Follow up?
So my question was, it seems like it should be like an insurance department issue. That was my
Yes, I understand that, and I didn't address that part of your question. So one of the two Supreme Court cases I referenced, the Group Life versus Royal Drug, spoke to the McCarran-Ferguson Act, which is an act that is related to insurance. And so to that extent, I can understand your question saying, well, isn't this an insurance issue? The ruling's core principle applies broadly. Healthcare markets cannot use exclusionary agreements to limit competition. And HR 14 addresses those anti-competitive practices in a broad fashion, right? And I think that any reasonable interpretation of the Supreme Court ruling would understand that it extends to healthcare providers and to pharmacy companies as well as it does to insurers. And by the way, the other ruling is predicated upon the Sherman Antitrust Act and has no insurance specificity to it.
Other questions? Seeing none? Okay. Representative Fowling, thank you.
Thank you, Mr. Chairman.
No one else has signed up to testify. Does anybody else wish to? Seeing no one else, that is the last hearing we have scheduled until 1 o'clock. So I'm going to close the public hearing on HR 14. We'll be in recess until 1 p.m., at which time we'll hear HB 455. We stand in recess.
Donald.
Okay, welcome back to the House Committee on Health and Human Services and Elderly Affairs. We have one more item to be discussed today and here in public hearing. That is HB 455. The prime sponsor, Representative Jess Edwards from Rockingham County, can't be with us this afternoon, but Representative Lucy Weber from Cheshire County will be introducing the bill. And the chair recognizes Representative Weber. Thank you, Representative Weber, for pinch hitting.
Thank you, and I actually was supposed to be on this bill, but life intervened and I didn't sign off in the right amount of time. The bill came out of reporting which is done to the Health and Human Services Oversight Committee for the relatively recently established enhanced provision of services for pregnant women. We extended the time, and when we extended the time, we also required quarterly reporting on that program. And I think that the purpose of this legislation is simply to repeal the quarterly reporting requirement as of July 1st, 2025. So, because it was felt that the program is established, we don't need to have quite as many reports. So that's the entire import of the bill, and I would defer to Mr. Lipman on any questions you might have, but it was at the request of various members of the Health and Human Services Oversight Committee.
Thank you very much. Good afternoon, Mr. Lippman. Welcome back.
Thank you, Chairman and members of the committee. Henry Lippman, State's Medicaid Director. And this came out of a discussion at, as was mentioned, at Health and Human Services Oversight. The way the original legislation was enacted, it was a forever reporting. I think this is saying to, and I think this actually came at Representative Edwards' suggestion, was to have some endpoint of the quarterly reporting, and that is at the end of the biennium, 2027. And we supported his suggestion and would appreciate if you would enact this.
Okay, so the department does support the bill, then?
Yes.
Okay. Are there any questions for, yes, Representative McLean?
Representative Wood raised his hand.
Oh, I'm sorry. All right, gentlemen, who wants to go first? Representative Woods.
Thank you, Mr. Chair, and thank you for taking my question. This is just perhaps exposing my ignorance. Number 2, Section 2 repeals RSA such and such, but Section 1, usually it says, after such and such, insert the following, or da-da-da-da-da. Nothing is inserted, so it almost looks like the repeal takes place and the reporting is that was there is deleted, but the paragraph above it doesn't say to insert it in a particular place. And almost as if it, it seems like there should be some reference to installing that reporting mechanism in place. And I may just be reading it incorrectly.
I believe that the language up at the top is the existing language of 4D, which is what would be repealed, and the reason it's not in bold is because it's already in statute. Because if I read 4D, although it does have a different date, it starts at 2024, so I'm not sure about the fact that there is no reference for insertion on the first part, and I'd be glad to go and check OLS about that. I know I've gotten into muddles before with repeal dates because you have the statute and then you have the effective clause and then you have the repeal dates and they're all in different places.
Right.
I think this one's okay, but I'd be more than glad to go and check on it to make sure it does
Here's the RSA. That's
what's wanted.
That's being deleted.
And And it does not say that section 1 replaces,
Yeah, that's.
which I think we may need.
Yeah, that was my question.
So I will undertake to find out about that.
Okay, thank you.
That was my,
Or bring an explanation for the executive session.
you said it more concisely, that some replacing would be the.
Representative McLean and then Representative Mazer.
Thank you, Mr. Chair. Thank you for taking my question. So it looks like they're going to sunset the report. So I guess what I'm trying to understand is because I'm not familiar with these quarterly reports, are these quarterly reports common in other areas to do tracking? And is it normal that they just kind of like have a shelf life and that they sunset? I'm just trying to get the, what is normally the scope of these quarterly reports and do they sunset? So
For the Medicaid program, can speak to that, what I'm responsible for. I believe right now this is the only report that I have to HH's oversight that's required legislatively. So I think historically, when the postpartum coverage, part of the Momnibus 1.0 initiative, there was interest to make sure that the department timely sought the state plan amendment to be able to provide that coverage, which we did. So that was one part of the report, which we can say every quarter that back in October, we got this in 2023. And so that part is really passe. The part now is to see whether how the benefit is being used and whether people are getting access to it. And I think, reporting forever on it, I think is part of an issue.
Representative Mazer and then Representative Weber.
Yes, thank you, Mr. Chair. So kind of following up with what Representative McLean asked, is I can see, a change to the reporting not being quarterly, but why not make it at least like once a year or twice a year? Because correct me if I'm wrong, wouldn't it be a worthwhile report?
So we do think it's worthwhile to do on a quarterly basis for a period of time, as opposed to having a quarterly report forever, if you will.
All set?
Kind of.
Representative Weber.
This isn't actually a question, but I can put it in a question if you'd like me to, but I know why it's drafted this way now. I figured it out. My guess is that because Section D was a permanent reporting requirement, it was put in the statute. Because what we're replacing it with is a temporary reporting requirement, it would only go into chapter law. It would not go into the statute. And so what this is doing is repealing D, which is in the statute in its entirety, but the part that isn't inserted in the statutes in any particular place becomes part of chapter law, and it's a requirement, but chapter law is used often when it's a temporary thing that's happening that doesn't need to be a part of the statute. So that's my guess, but I will find out about that. Right. The law is that which is boldly asserted and plausibly
Representative
maintained.
McLean.
So, and thank you very much for taking my question. So I can understand, you have had other quarterly reports. They have sunsetted if things have come along, and this is the only one that remains, and it, like the other ones, is going to sunset. With all these reports though being sunset, maybe you're not making reports, but do you have things in place now that are continuing to track once we go beyond these sunsets, the efficacy of these programs? And are they reported out at some time, or this is just data you're collecting? So I'm just trying to understand what survives beyond all these quarterly reports.
So I think in terms of the Health and Human Service Oversight Committee, anything they're interested in, we come and make a presentation on. So for example, the adult dental benefit implementation. That's something that wasn't a required report, but it was of interest to track what was going on, and we report on. The unwind of continuous coverage, that was something that we reported regularly for a period of time till that was completed. I imagine if legislation passes this session about the governor's budget related to eligibility or premiums or what have you, that would be something that they would expect us to speak to them about. New waivers. It's really at the discretion of the chair, and the committee will report what we want to keep them informed the way they want to be kept informed.
Follow up?
So just to clarify, so you're not going to be making any reports outside of a request, but you are continuing to gather all the data so that if a question should arise at some point in the future, you have access to that data to generate a report kind of on demand.
Pretty much. I mean, I think if they had something esoteric what we're trying to look at here is, are women taking advantage of this? So we look at eligibility and see people being enrolled. And then the purpose of extending beyond 60 days to a year was to make sure that, it's hard to get medical appointments done in 60 days in this environment, but, what types of services are they accessing? And what results are we seeing in terms of maternal mortality or neonatal mortality that these types of services supporting would support? Just as a matter of background, we were one of the earlier states to adopt this. There are now 48 states that have, and the 2 that haven't have pending legislation to actually add even more than what New Hampshire has.
Thank you very much.
Mr. Lippman's point, when we exec the bill on the ALS registry, that's a new issue that we've asked oversight to look into, and we discussed at our last meeting. So to Mr. Lippman's point, they're very good about following up. The department is about any requests the oversight committee has. Representative Weber.
And I will ask this one in the form of a question. Isn't it true that when we stood up the Doorways program, you reported, again, that was initially a governor's program, so it was not in statute, but it's true, isn't it, that you reported to the committee, the oversight committee, once a month for about 2 years?
I believe that to be true.
Yeah.
Other questions? I'm seeing none.
Mr. Chairman, at any time this committee would like any information that, we want to keep you apprised so you can make good policy. And we appreciate all the support this committee has given in the last number of years to improve eligibility policy and coverages in New Hampshire. So thank you.
Okay, thank you. I won't ask if anybody else wants to testify, unless there's somebody hiding under a table or a chair or something.
You'll be haunted.
So with that, I will close the public hearing on HB 455. There were no other bills or resolutions before us today. We do have a hearing scheduled for next week, and I apologize, Representative Weber. A number of you did not know we were meeting on Monday, and on a couple of bills that are expected to get a big crowd. That's why they got put on at their own day. And then we have a normal meeting schedule on Wednesday, at which time there will be some executive session issues as well. Any questions before, Representative Woods?
Was there any concern, when I saw the type of bills, any concern that they might be wise to move it to Reps Hall?
There will be an overflow room too.
That was raised, and they're
Okay.
trying to discourage hearings in Representatives Hall.
Yeah, because I would anticipate.
Because I raised that question myself
Okay.
with the staff and so forth. For a number of reasons, they would prefer to try to do it in a double room with an overflow room. Also, given the nature of these bills, we never know what the nature of the crowd will be, the size of the crowd will be. And I've also expressed some concerns that there be security also. So in the event it's necessary, not that I expect anyone to be physically endangered or anything, but just in terms of crowd control and stuff like that. So
Just a question. Yeah.
Sure.
I expect a big crowd.
Any other questions, or if not, we'll adjourn. And again, I'll see those of you who can make it on Monday, or I'll see you next Wednesday. We stand adjourned.
Would you like me to draft something that requires an annual reporting, just for people's consideration?
Okay.
I'd be glad to do that.
I think if they have one, I'm okay with it, as long as they're continuing to keep the data, which can be called for on demand.